Good morning and welcome to another episode of Roll Call TTSH Nursing's very own podcast brought to you by the Centre for Asian Nursing Studies. I'm Kim as always, and today I have a really exciting episode that I would love to share with you guys. So the clinic practice nurse role, also called CPN, in our specialist outpatient clinics is a relatively new role that I'm sure many of us haven't really heard of before. But as always, you don't have to worry because I got the tea and the right people to share more about this fantastic role with us today. So join me in welcoming Deputy Director of Nursing, Sister Karen, and Assistant Nurse Clinician, Ting Ting.
Hi, good morning.
Hi. Okay, so let's kick things off with a round of introductions. Please take turns to introduce yourselves.
Hi, I'm Sister Karen here. I'm the Deputy Director of Nursing, overseeing SOC. Basically, I'm looking at the progression and the development of my nurses in 31 clinics. Okay, over to you, Ting Ting.
Hi, I'm Ting Ting. I have been working at Clinic B1A for 8 years. So I'm providing care and procedure for patients with orthopedic, rheumatology, allergy and immunology conditions. I'm also part of the first batch of clinic practice nurses.
Okay, so what is a clinic practice nurse and what do clinic practice nurses do?
Okay, maybe I can help to answer the question. Basically, a clinic practice nurse is something we kind of coined that term because we have advanced practice nurse, we have nurse clinician, but we never heard of clinic practice nurse. So we thought, why don't we call ourselves clinic practice, because we are practicing in the clinics. If you look at clinic practice nurse role, is traditionally the SOC nurses is very transactional, meaning patients come in and out. It's an episodic visit. They do the basic requirement of nurses like taking the blood, doing the dressing. As in the past, we even assist the doctors in the consult room. But our nurses are no different from any other nurses in the inpatient care setting, in the ED, in the operating theatre, in ICU. We all go to the basic nursing diploma. Then of course some of the nurses we also do advanced diploma, specializing maybe in diabetic care or urology or neurology. And then some of our nurses also, in alignment with the development of our professional nurses, we do degree and we do masters. So the thing is, what we wanted to do is that the landscape have changed. There's an evolving need. Our patients need to, our nurses need to practice on top of the license, and moreover with the healthy SG, we are looking at preventive care. So I think that's where we wanted to have our nurses, how they can help these patients manage their own health by embarking on preventive care. And when they come to the clinic, of course we do have our core duties as a SOC nurse. On top of that, we want to do this patient education, we want to do medication adherence, we want to have a coordinated care for the patient. Okay, I think that's how the word CPN came, clinic practice nurse.
Before we go into how specifically do we get into this CPN program, how were they chosen and all that. So thinking as a CPN, right, let's skip some questions and go right into it. What do you do in the orthopedic, in your specific clinic B1A as a CPN?
Okay, so I'm trained in orthopedic clinic. So I'm trained to look after patients with osteoarthritis knees. So we call it adult reconstruction clinic practice nurse.
Wow, okay, very long name.
So being a first batch of CPN nurse, and also I will share with you my days, how it looks like. So my clinic, the CPN clinic runs every Thursday with 4 patients in the morning and 4 in the afternoon. So I mainly look after 3 groups of patients. So firstly, stable post-op patients. It means those who are 1 to 2 years after their total knee replacement. So I will look up for any implant issue and how is their knee, is it stable or not, and also how are they coping at home. And for second group of patients are those with post-op wound issues such as stitch sinus or allergy to dressing products. So I will educate on wound care and what are the appropriate dressing products that they can use, and also monitor how is their wound healing process. The third group of patients are those with mild osteoarthritis knees and does not require a total knee replacement yet. So I will re-educate on their condition and what are the exercises they can do at home and what are the exercises they should avoid. at home, and also teach them how to handle flare-ups so that they are more prepared and less worried if they have knee pain at home. And I think this covers my role as a CPN nurse in the clinic. And on other days, I provide general nursing cares like casting, dressing, and IV infusions, as well as assisting my clinic managers in overseeing the clinic operations.
Maybe just to weigh what Ting Ting has said, as you can see, she's very experienced. So back to Kimberly, your first question, the selection process. Firstly, the selection process, I must have a nurse who have enough experience in SOC. Okay, it's not a new graduate, and Ting Ting is not a new graduate. She's a senior staff nurse. Okay, that's first criteria, experienced nurse. Secondly, she's also possessed advanced diploma in orthopedics. So she already have this basic knowledge looking after orthopedic patients. And thirdly, she must have this collaborative teamwork, because it's not a single person looking after this patient. We need to collaborate together with the physiotherapists, with my inpatient counterpart and my clinician. And also a good communicator and very patient-centric, okay? Because this one, she need to understand the patient, and not every patient is the same. Every patient is different. Understand their social needs. How can we, she will kind of advocate these medication adherence, compliance, and especially doing the exercise and all that. And in the past, this role, you'll be surprised 3% did. Okay, it was done by a doctor. It was done by a coordinator, and it was done by a nurse. So 3%. So to one of the reasons this CPN role is a bit unique in the sense that she is a single point of contact for the patient. So at any point of time, patient have any queries or any questions he or she need to ask about the post-recovery, the person need to get in touch with Ting Ting. No need to go to 3 different people.
It can be very confusing.
Correct.
Also,
And patients feel that it's very fragmented care. We wanted this a very seamless care and well coordinated. So that's the difference, and that's the value a CPN brings both to the patient and as an organization, partly because this relief of doctors to look more complex care. Because now the first time clinic nurses are actually doing patient fronting, and they have their own resource to run the sessions. So moving forward, as this, we need to see what is the indicators and how effective is this CPN, then we can bring in more CPN to have this role. Because as you know, we don't have many medical doctors also to kind of do this role, which our nurses can be upskilled to do this. Just to add on what Ting Ting has said.
Thank you.
Thank you. So I think just now, Sister Karen, you shared that like the best of the best.
Yes, the best of the best.
CPNs, right? So I think maybe Ting Ting can share like how was your training process like? So once you were chosen and selected, then after that, before you became a CPN, what was the entire phase like?
Sure. I'm happy to share about my training experience. The training has 2 parts, the foundational and the unit-specific training. The foundational training was a 3-month course which covered very important and very practical knowledge on patient care, such as history taking, physical examinations, lab interpretations, and chronic disease management. So this helped me to have a better understanding of patient's condition and how to identify abnormalities and provide safer patient care. So the second part of the training, it was a unit-specific training. So in the orthopedic clinic, I was trained to provide holistic care for patients with osteoarthritis knees. So I was attached to different departments, the pre-admission care and counseling department, the day surgeries, the operation theatres where the surgeon carry out knee replacement surgeries, as well as inpatient wards and also clinic sessions, how the doctor run the clinic. I had a better understanding of how patient's journey looks like, and also how patients with osteoarthritis knees were managed at different stage of care. So this allows me provide more informed advice to patient.
How long was the training process like?
About the foundational training was about 3 months, and for the unit-specific training was about 2 to 3 months as well.
I see.
So the overall whole process took us about
half a year.
Half a year, partly because the theory part was not an issue. Because the theory, we ring fence the clinic nurses to come and go for the theory, right? That one is not an issue. But the assessment part was a bit challenging, partly because this is where they will be assessed by our APNs and the clinicians. Basically, are they doing correctly? How do they do the physical examination? And we need to, because our APNs and NCs are also running sessions. So basically, we need to work very closely when is the available time for them to assess the nurse. So that one took a bit longer. Yeah. And then some of the nurses, they also need to master the unit specific. That means you do the overall general, then you need to master the unit specific. Yeah. So they had these CX and all that, right?
Yes.
Mini CX where they actually do direct observation assessment and all that. Yeah.
So for the assessment wise, there was like a mix of both theory and practical.
Yes.
Correct.
Was it very stressful?
Yes. It was. It was.
I think the first batch they found it stressful because they're the first batch, and the first batch we had 10. But the second batch benefited because we have another 10 of them trained because the first batch was able to guide them.
Yes.
So the second, in fact, the feedback I got from the faculty, hey, your second batch is better, no? Because I think the first batch was able to mentor.
Yeah.
So and they were all from the same discipline, meaning that every discipline have now 2 CPN. This is partly because to ensure there's continuity. So that when the one staff goes on leave, another staff will take over.
I see. So now at this point in time, how many batches of CPNs do we have?
We already have 2 batch because you must understand this APN on top of their clinical work. They kind of very kindly conducted this. We formed this faculty. Now it's taken over by nursing education. So under LNA, learning need analysis, we kind of project who are the nurses who want to go for the CPN. So it's very, they took the same structured program when the APN did it. Now we put it under LNA. So we already have about 5 nurses who have already registered they want to be a CPN under LNA. So this will be taken by nursing education.
Okay, I see. Okay. Then the courses itself, it wasn't like a full-time thing, right? You were saying that I think it's like once a week or something like that?
Correct. It was twice a week, 2 hours a day. Yeah.
2 hours a day.
Yeah.
Wow, so like on top of your own clinical work,
Yes,
or like you go back, you need to study and revise.
Yes,
correct. Then they must do journaling also.
Wow.
Yeah.
I always say I really respect people, right, who like do like part-time studies, or like you have to study all this kind of thing on your own time. Like, so I'm so used to like, okay, after I do my work, okay, like when I was still mostly in clinical, like you just do your work, then after that, okay, you clock out already, right? Okay, go home, don't need to think about anything. But want to do like especially when you're part-time studying and going for courses like this, at least it's over.
Yes.
Okay.
By the word of mouth, even our doctors are saying, hey, I want to ask your CPN to start this service, Then I say, you wait, I only got 1 CPN, you wait. And also, I still need the BAU work need to be done, right? So this is how we actually kind of, support the clinic with this CPN role with the buffer nurses. So the BAU work will still continue because we still need the BAU excellence. Okay, BAU means
business as
as
usual.
usual. That means those patients are still coming for my blood test, dressing. This one still I need to continue. This is on top of it.
Yeah, I see. Okay. So, Ting Ting, as the first batch, as a graduate of the first batch of CPNs, right, how has the role been like so far? You graduated from the role, it's been
2024 February.
Yeah.
Yes. Okay.
So how has it been like the past year plus?
Okay. Being part of first batch of CPN nurses, it has been a rewarding learning journey so far already, in looking after patients with osteoarthritis knees. And I think it was a very good opportunity to explore how outpatient nurses can contribute further in terms of adding value, provide more care for patients, especially when there's increasing needs in degenerative conditions in aging population, right? And at the same time, I realized that I have been gradually building rapport and trust with patients. So we get to spend more time with patients, talking to them and answer their questions. So that they feel more supported and they know who to contact. After they go home. Of course, there were challenges at the beginning. So as the first nurse running a clinic in outpatient setting, not the first nurse, first outpatient nurse running a clinic in outpatient setting. So I was initially overwhelmed by the new role and also what lay ahead. But I think what really made the difference was the incredible support from everyone around me, my colleagues, my clinic managers, the doctors, and also MEC ops.
do you get similar feedback as well from like the other CPNs,
Yes,
especially from the
I
first batch?
do get, because Ting Ting is not the only CPN I have. I have this colorectal, where I told you they manage my ERAS patient. We did a survey for all those clinics that have CPN. In fact, the patient, I think the satisfaction rate is about 8 to 9. 8 to 9. They're very satisfied, because I think being nurses, I mean, we join nursing because we want to have this humanistic touch, we want to have this therapeutic care. And I am not saying doctors don't have, it's just that being a female, majority of nurses are female, and I feel that the patients, certain things they cannot tell the doctors, they feel very ease, very comfortable, and then most of my nurses are very young, they're in their 20s and 30s, like telling their daughter what's the problem and how they can help, what are the issues they have. So I also have a nurse in another clinic where we manage obesity patients, and now the nurse is actually have taken some of the workload from the doctors, and we do see result in the sense that our patients are satisfied. If I look at other indicators, my attrition prior to this CPN role, attrition means nurses are resigning or who have resigned, used to be 12.2%. Okay. And specialist clinic, our volume of nurses compared to inpatient care setting is only about 300. So it's a bit, a very stark, the numbers. But ever since we started this CPN role, my attrition has come down to 5.2%.
Wow.
Yes, 5.2%. And my nurses' satisfaction also have gone up. It used to be about 2.3, I think. But now, because the nurses feel very satisfied, because they join nursing because they want to have nursing care, and they don't want it to be very transactional. So they feel very satisfied. They have kind of, have shaped this patient's journey. That means they're seeing the patient from end to end. So these have kind of elevated, and they feel very good practicing on top of their license. So I can say that offhand that these are my two indicators that shows that nurses are very happy doing what they're doing. Yeah. And also, it's a teamwork, right? It's not just my nurses. As what Ting Ting said, I'm very thankful for those other stakeholders who gave us the opportunity to go to operating theatre, to PACE, and even to my allied health, the physiotherapies, and my inpatient counterpart, allowing Ting Ting to have have a better understanding what these patients go through during surgery and post-surgery and the recovery to home. Basically, we want this patient to be in the community so that we can look after more acute cases, and these patients are kind of self-managed by themselves. Of course, at any point of time, they know who to contact. They have issues. Then they know, they look for Ting Ting. Now I have a second nurse who's going to do my next CPN role in this MSK, musculoskeletal, is total hip replacement. Now we started total knee, right? Next phase is total hip replacement. I'm also going to start another CPN role that I already started is the change of PEG. PEG, is the percutaneous endoscopic. It's always done by doctors. Now my nurses are trained. They already started in the change of the PEG.
Oh wow.
Yeah. So we are in a different phases where my CPN are already upskilling.
Wow, that's super duper fantastic. Actually before this interview, I also didn't know about the CPN role. So I'm very, very thankful. I mean, obviously this portfolio really exposes me to a lot of this wonderful work that our nurses are doing. And I'm so glad that, we have this platform to showcase it to everyone else. And to also thank you for all your hard work on the ground as well. Okay, but of course, right, I think as with every CPN, I think I also heard from some APNs as well. When you run your own clinics and all that, right? Just a question before we end this episode. Has there been any misconceptions or perspectives by certain patients, right? Where they ask you, I prefer to still see a doctor. I don't want to see a nurse. Because I think, nurses now, I think we are empowered to do a lot more roles and a lot more skills, higher level skills and all that kind of thing. But I feel like there's still quite a common misconception by a lot of patients where they're like, no, that one is still left for the doctors only. Have you faced any issues or challenges when it comes to that during your clinics?
I think this is a good question. So far, no. In fact, I agree with sister. I do notice that patients and family members, they are more open and comfortable with nurses. So we can address their concerns and acknowledge their issues timely. But if it happens, I think it's their right and we should respect that.
Of course.
I believe building building trust takes time. Yeah, and what's most important is to help the patient and the relatives to understand that both doctor and nurses work together, and we all want the best care for them.
Of course, of course, of course. Thank you so much for sharing. I can feel the wisdom and the knowledge radiating from that side of the room to me. So thank you so much for joining me on this episode of Roll Call.
Thank you.
I really enjoyed myself, and I hope that you guys enjoyed yourself too.
Thank you.
So that concludes this episode of Roll Call. Thank you so much for joining us. Remember, you can also check out our podcast episodes on Spotify, other than YouTube. So just search us on Nurses of TTSH. You can also follow us on Instagram and TikTok if you haven't as well. And that's all from me for now. Thank you everyone, and have a great shift. Bye-bye.
Bye.